Hello, hello. My name is Qing Chang, and today I will be presenting on Graves' disease, an endocrine disorder caused by hypothyroidism or overproduction of thyroid hormones. Graves' disease is an autoimmune disorder that affects the thyroid gland, a butterfly-shaped gland located in the anterior neck, just below the larynx. In this condition, the body's immune system produces abnormal and auto antibodies called thyroid stimulating immunoglobulins (TSIs). These antibodies bind to the thyroid stimulating hormone TSH receptors on the surface of thyroid follicle cells, causing continuous stimulation of the thyroid gland. This leads to the excessive secretion of thyroxine T4 and triiodylthyronine T3, two key hormones responsible for regulating metabolism, heart rate, and body temperature. The clinical manifestations of Graves' disease are often related to an overactive metabolism. Patients typically present with tachycardia, abnormal rapid heart rate, unexplained weight loss, heat intolerance, tremors, and increased perspiration. On one distinctive feature of the exophthalmos or bulging of eyes, which occurs when immune-mediated inflammation causing swelling of the tissue behind the orbit. Another common finding is a diffuse goiter, which is an enlargement of the thyroid gland that can be thin or pipetted in the neck. The exact cause of the Graves' disease is not fully understood, but it is believed to involve a combination of genetic predisposition and environmental triggers, such as stress, infection, or exposure to the iodine. It is more prevalent in females, typically between the age 20 and 40, and is often associated with other autoimmune disorders, including the rheumatoid and arthritis and the system, lupus erythematosus (SLE). To diagnose Graves' disease, clinicians use several diagnostic tests. Serum thyroid panel shows elevated T3, T4 levels with suppressed TSH. The thyroid antibody test detects the TSI and the thyroid peroxidase (TPO) antibodies. Radioactive iodine uptake (RARU) scan reveals increased uptake by the thyroid gland, confirming hyperactivity. Ultrasonography may also use to assess gland size and vascularity. The treatment depends on the severity and the patient's overall health. There are three main approaches: antithyroid medications such as methylmazole (MMI) or pyrrolthyrouracil (PTU), which inhibit thyroid hormone synthesis. Radioactive iodine therapy, which selectively destroys overactive thyroid tissue. Thyroidectomy surgery, removal of part or all of the gland, reserved for patients with large goiters or those unresponsive to other treatments. Symptoms control can be achieved with beta-adrenergic blockers such as propranolol to reduce tachycardia and tremors. If the hypothyroidism develops after treatment, the levothyroxine, a synthetic T4 replacement hormone, is prescribed to maintain normal metabolic homeostasis. With appropriate treatment, most patients with Graves' disease achieve euthyroid status, meaning normal thyroid hormone levels. However, relapse can occur and allow lifelong monitoring through the chronology. Follow-ups is often necessary. In conclusion, Graves' disease is a classic example of how autoimmune dysfunction can disrupt the endocrine system. Understanding its pathophysiology and clinical presentation and treatment options is critical for recognizing the balance between the hormone regulation and immune control in maintaining health. Thank you for watching. Again,